please. So thank you.
Hello, I'm Andrew Coates. I'm president of the Heart Failure Association and also from University of Warwick in the UK and Monash University in Australia. I'll be talking about a rapid self-administered heart failure risk test that's been developed in an Australian company, ESN Clear. First of all, here are my disclosure statements. Heart failure, we know, is a common and extremely costly disease. It's one of the leading causes of mortality and disability in the developed world. Causes 10 million deaths a year, costs $100 billion each year, and it's associated with a very frequent rate of rehospitalization and significant unmet need. Despite multiple effective treatments, we still have residual heart failure burden that's unacceptable to our healthcare systems. What we would like to see is a reliable way of detecting the risk of heart failure much earlier. We have multiple treatments, 6 or 7 devices or drugs that can reduce mortality, morbidity, and heart failure, but only once heart failure has been diagnosed. And it's the tragedy of this condition that sometimes the first diagnosis of heart failure is when a person's admitted with acute heart failure, and that may itself be a fatal event. So wouldn't it be better if we could have a reliable test to say this patient's at high risk, maybe imminent risk of developing heart failure, and start some of these effective treatments before that catastrophic event of an acute heart failure causing heart failure hospitalization. What we would like and what we believe we're developing is an early heart failure test kit that can be both a conventional test that's taken to a laboratory, or we have simplified it so it's an electronic device that can be used by the patient with a long shelf life that detects a simple biological fluid, that of human saliva, to detect patented biomarkers that tell you the risk of developing heart failure in the near future. The science and technology platform that's been developed by ESN Clear is bespoke, sophisticated, modern. It involves a non-biological long shelf life antibody type mechanism linked to a nano device sensor that detects the antibody collection to specified biomarkers, and there can be multiple biomarkers in a simple small head, and that can change the electrical resistance, giving a score or a graded response in terms of the risk. So it's a way of measuring multiple biomarkers simultaneously, give a simple, easy to use result, and can assess multiple biomarkers at the same time. It involves development, miniaturization of electronics, and this dry antibody technology. We then have proprietary intellectual algorithms that can look at individual biomarkers, and we have novel patented biomarkers, but in a way, in a grouping and in a weighting that can be fine-tuned to focus in on a particular aspect of the heart failure syndrome, a particular stage in heart failure, and even particular subtypes of heart failure, with the possibility in future of concentrating on heart failure with preserved ejection fraction or mid-range or mildly reduced ejection fraction, as well as perhaps even in the future different subtypes. It can also be used to follow the progress of heart failure, and this could be particularly attractive for patients who are high risk or patients who have difficulty getting to hospital or clinic, such as patients in rural and remote locations or patients with poor mobility and poor social support. So you see there's a lot of flexibility in terms of the platform of device that is being developed. We believe that some of the value is not just the device may be purchased for its use in clinical practice, despite what we see as significant opportunities for improving clinical care, but also it can reposition our drugs so that they have an entirely new market. If we consider the spectrum of healthy patients through conventional cardiovascular risk factors to establish heart failure, and here we've called it stages, but it's probably more easier to summarize that as NYHA classes 1, 2, 3, 4, from minimally symptomatic through to severely symptomatic. But we have patients who are just on the border zone of getting heart failure, who clearly have early abnormalities in biomarkers we're only just beginning to explore. If we can detect those biomarker patterns by a simple fluid such as saliva testing, then we can identify patients just before they're developing their acute heart failure which of course is such a high risk condition. And this is a way of establishing a new protected market for established cardiovascular drugs. And I'll go through the examples of that in the next few slides. So there's an untapped market segment where our test, ESN Clear test, can detect a patient who is at imminent risk of developing heart failure, and then drugs that prevent heart failure hospitalizations, such as, for example, the SGLT2 inhibitors, can be given in this patient cohort, defined by being positive for a patented diagnostic test. And then a relatively reliable clinical trial can be conducted, knowing these agents are powerful at protecting against heart failure hospitalization. And once you have that secondary trial proof, then you have a segment of the patient population which is protected for you because the diagnostic test is protectable. The patient journey is that they can take these devices home, they can monitor themselves for a risk, they can take the test, and if the results come back showing high risk of future heart failure, they can get a full clinical assessment, and they can, in future, once we have clinical trials establishing the benefit, take heart failure treatment without actually having ever suffered an acute episode of decompensated heart failure. Now, to give you an example of the market, if we concentrate now on the SGLT2 inhibitors, the two lead agents, dapagliflozin and empagliflozin, but of course there are others showing similar benefits, such as sotagliflozin, ertugliflozin, canagliflozin. Then initially they started life as hypoglycemic agents prescribed to patients with type 2 diabetes, but without particularly strong market penetration because they're relatively modest efficacy in terms of hypoglycemia. They now, through trials such as DAPA-HF and EMPA-REDUCE, have been shown to work in established heart failure with reduced ejection fraction, but that, of course, is not a hugely common disease compared to other cardiovascular disorders. But there is a much larger population out there of patients at risk of developing future heart failure, which is patients with a range of cardiovascular disorders, patients with mild diabetes or insulin resistance, or metabolic syndrome, and of course patients with other cardiovascular risk factors, including old age. And if we can assess and promote the use of these tests, then we can develop these patients. If you now look at the financial impact of that, here is an adaptation of the European present guidelines that basically has a sequential effect for adding drugs. So we start off with ACE inhibitors, beta blockers. We then assess if the patient is still symptomatic and consider adding a mineralocortical receptor antagonist. Then we wait again after up titration and then consider converting to Novartis's sacubitril/valsartan or Entresto or other treatments such as ivabradine. And you see that this is multiple steps down the pathway. If you look then at the prevalent use of these agents in market penetration, we see about 80% plus for those who are listed in the first step, about 40% in the second step, but the drugs, even though they're showing dramatic benefits, are only getting market penetration of 10 or 20% after 5 years in the case of Entresto, because they're so far down the algorithm. What we want to do is accelerate the algorithm and make it earlier. So if we then consider that SGLT2 inhibitors can be used also in diabetes, they're floundering low down in the diabetes algorithm, so there's very little use there. We go back to our large population potentially at risk for heart failure. We then test them with this saliva test, the ESN positivity test, and we identify these patients, the red people, who are at imminent risk of heart failure. They then can be targeted. It's an entirely untapped market. We have brown patients there because our biomarkers could also potentially be focused on detecting a high risk of a side effect from an agent. So we get a companion diagnostic test that is both enriching for patients at risk of the disease, but also we can identify those who may be not the ideal candidates because they're at high risk of a side effect. So the potential benefit from an SGLT2 inhibitor is this group from the normal population with risk of heart failure. We can identify those at high risk, and then in future guidelines, instead of waiting until you're the fifth agent in the heart failure guidelines, you get at the very top, where if you're at risk for heart failure, if it's because of hypertension, you follow the hypertension guidelines. If it's because of diabetes, you follow diabetes guidelines. But if you're detected at risk, if your patient is detected at risk by the ESN Clear test, then the patent protection for that test linked to the patent protection for the composition for the companion diagnostic with drug means that we have a patent protected indication for a drug that even could expire that of patent expiry for the chemical itself, because of course you have to have the companion device to be able to prescribe and get reimbursed the drug, and you can't infringe that patent. The cardiovascular benefits of SGLT2 inhibitors I mentioned have been fairly broad, and they've been reducing major cardiovascular outcomes. But if you look there at heart failure hospitalization, that's the one where the majority of these agents very consistently reduce the risk of future heart failure hospitalization, but you have to have a diagnosing condition. So if we now introduce ESN clear test positivity as an at-risk condition for heart failure, it would be very simple to design a clinical trial to prove that your gliflozin, your SGLT2 inhibitor, can prevent the composite endpoint of heart failure hospitalization or mortality in the group of patients you have so detected. We have seen that multiple SGLT2 inhibitor trials in type 2 diabetes do reduce heart failure hospitalization, as well as other benefits, but the consistent, powerful one is preventing heart failure hospitalization. So we have calculated the market based on a companion diagnostic of this early heart failure risk test with a heart failure drug that's protected because it's been established to be useful in patients detected by a patented test. And we can see that the additional treatments offered to additional patient segments will drive substantial value years down the line. There is continuous growth because we have the initial tests and we can develop other products, we can develop other market segments and other disease states along the heart failure spectrum with bespoke products because we detect multiple biomarkers with an intelligent learning algorithm that can fine-tune the test related to the stage of the disease we want. There is a demand for such technology. We know that's growing, and this is a composite companion diagnostic with established therapeutic options. There is a strategic partnership opportunity between major drug companies with drugs, perhaps coming soon off patent, combined with our patented test, both the laboratory version and the hospital home use version. And we are an experienced team, executives and board of directors, experienced in the financial sector, pharmaceutical sector, and the medical sector. So we encourage you to consider this device as we further develop it and popularize it, and we are accumulating the clinical evidence necessary to convince the skeptics that this truly is a major breakthrough forward. So we would like to leave you with the contact details for our CEO, Leo De Bruin, based in Australia, and thank you very much for your attention.
I would like to thank the organizing committee for the invitation to participate in this session. The subject of my presentation is heart failure with reduced ejection fraction, new treatment paradigms. These are my disclosures, and specifically this presentation is sponsored by Boehringer Ingelheim. This is a summary slide of the Paradigm Heart Failure trial published in the New England Journal of Medicine